It's hard to navigate. All right. Thank you so much, Tom. So I have the privilege of talking about the diabetic retinal disease staging update. And as you saw from Robert's first slide on the Mary Tyler Moore Vision Initiative, this was really the first plank in several phases of the work to follow. And we're talking about this just before the breakout sessions because we hope that this will really start the discussion on priority endpoints for our groups. Here are my financial disclosures. So the DRD staging project arose out of a growing realization in our community that although the ETDRS diabetic retinopathy severity scale and similar scales like the international classification scale have been very useful for many decades for us to stage retinopathy and risk stratify our patients, they have very important limitations. For one thing, they only address the vascular components of the retinal disease, and that was remarked upon by Dolly Chang in her talk. We also know that they only look at a portion of the retina, the central 90 degrees, and we have the ability now to image and to document much wider swaths of the retina out to 200 degrees. The DRCR Retina Network Protocol AA recently reported looking at association of predominantly peripheral lesions on the ultra-wide field images, did not find an association with predominantly peripheral lesions on the color images, but did find an association of predominantly peripheral lesions on ultra-wide field fluorescein angiograms with future risk of diabetic retinopathy worsening, independent of the patient's baseline DR severity level. And so perhaps these things might be incorporated, or perhaps they need to be incorporated in future systems. Fluorescein angiography, particularly the ultra-wide field images we get now, as well as the optical coherence tomography angiography images, are also allowing us to document non-perfusion of the retina and potential areas of retinal ischemia in ways that had not been previously accessible to us. And I'll point out that although it's very clear to us that OCT central subfield thickness is not a registrable endpoint, in part because of its only modest correlation with visual acuity outcomes, nonetheless, we use these structural images from the OCTs, as shown here, on a daily basis in our clinics to actually treat patients, to decide how to manage them, to decide when to start, when to stop treatment. And there are many morphologic changes on these images of the structural neural retina that may be better correlated with visual acuity than the thickness measurements themselves. So as we started the DRD staging project, our vision was that at the time of diabetes onset, we could start thinking about a much more multidimensional holistic scale that incorporated not just measures of worsening retinal vascular function, but also retinal neural function in the context of the biochemical milieu of the retina and within the greater context of the patient's systemic health, to understand both how these things impact patients' visual function and also how they take into account and impact patients' quality of life. Over the last year plus, we've engaged on this work with the really incredible collaboration from 6 working groups that we've charged to look at specific areas of focus in vascular retina, neural retina, basic and cellular mechanisms, systemic health, quality of life, and visual function. And you see the group leaders of these working groups listed here, all of whom I think are participating today, many in person and a couple remotely. And these groups, again, have really led regular meetings with brainstorming and consensus by teams of international experts that they've gathered to do a targeted review of the literature based on their discussions, with completion of very granular and standardized evidence grids for each variable of interest. Manuscripts have been drafted. We've sent them out for independent external reviews, and the manuscript revisions for some groups are in final form and for some in near final form. And again, we've charged them to do 2 things. One is to identify priority variables that might be incorporated into that vision of that multidimensional graph that you saw. In addition, and as became more and more apparent as we engage in this work, we asked them to delineate key research gaps. And there's no question that there's a lot of work that still needs to be done in this area. And there's a lot of validation that needs to be performed for us to really start to stand up truly new and updated staging systems. So this very busy slide is actually the output of all of our working groups, except for one. Helen Calhoun's Systemic Health Group did a truly fabulous job in a systematic review of risk factors for diabetic retinal disease. And their risk factors didn't quite fit the mold of the biomarkers that we were looking at in the others, but these are the launching pad for our breakout discussions today. And what we asked groups to do was to identify variables that were relevant to specific types of diabetic retinal disease in terms of along the severity spectrum. Subclinical DRD, disease that we said was not clinically visible or evident, and then early stage, mid stage, and late stage clinical diabetic retinal disease. And we deliberately left these very general because while we recognize that ETDRS, diabetic retinopathy severity scale, certainly allows us to pigeonhole early, mid, and late stage disease from a vascular standpoint, there were certainly other options that we wanted the groups to incorporate if they felt that it was necessary. We also asked the groups to parse which types of variables might be ready for current use or use within the next 1 to 2 years based on ongoing research. Those that were promising with unmet but clearly defined research needs that potentially could be accomplished within the next 5 years, and those that were potential and promising, but which had unmet research needs that would really need more than a 5-year window to accomplish. So what you'll see in your breakout sessions today, which will follow this, are variables that were specifically associated to retinal imaging, to visual function and retinal physiology, to patient-reported outcomes measures, and to systemic biochemical and cellular markers. So the DRD staging project, again, was really focused on biomarkers of disease. We were trying to fit these variables into a severity scale that could then be used to stage disease for thresholds of treatment need and risk stratification. How does this relate to what we're doing today in clinically relevant endpoints? Because there is a little bit of a difference and a distinction. So what we hope is that some of the biomarkers in the universe of biomarkers that we've identified through the working groups, and you are very welcome to also add additional biomarkers in your working groups that may come up during discussion. We certainly encourage that freedom. We hope that some of them, since biomarkers are really characteristics that are evaluated or measured as indicators of natural history, disease progression, or treatment response, what we really need to work for when we're talking about clinically relevant endpoints is to see which of these can then be subsetted into surrogate endpoints. Surrogate endpoints are the biomarkers that have been shown to have reasonable likelihood to actually predict clinical benefit. And typically, we do this through validating studies that use clinical endpoints that really directly reflect how a patient feels, functions, or survives. So we'll ask you in your breakout sessions to talk about which endpoints within your group areas might be clinical endpoints that directly reflect patient experience, and which ones might be surrogate endpoints that may not directly reflect patients' feeling, functioning, or surviving, but which could be correlated with this. Over time, we'll also ask you to identify which of these surrogate and clinical endpoints might have potential to bring into the registration space as primary endpoints for our pivotal trials. I'll point out that this kind of effort needs validation of these endpoints for a very specific context of use in specific cohorts for specific indications. And that's really the work that we're going to be doing this afternoon as we talk about the action plans to do this. So our breakout groups are in 4 areas, and if you're not sure which breakout group you're in, it is listed in the program in a couple of places. We have lists of the breakout groups. We also have lists of all the workshop participants with your group assignments in there. 4 areas of visual function and retinal physiology that will be led by Adam Glassman. Patient-reported outcomes measures by Stella Vajosevic, systemic biochemical and cellular markers by Lloyd Pauliello, and retinal imaging by me. Our morning session will prioritize the endpoints that we're talking about, clinical endpoints, surrogate endpoints, and then the subset of those that might have potential for registration trials. The afternoon session, we're going to really develop action plans for endpoint validation. I'll just close by saying, I think one of the really important things in this space, Tom talked about the fact that this is going to need not just this year's work, but 5 years work, 10 years work, potentially decades worth of work. So it's really important for us to identify folks that are going to be future leaders in the space. And so as such, we have 4 scribes in our breakout groups. Cindy Kai from Hopkins is going to be working with the patient-reported outcomes measures. Ruman Sachana will be working with the retinal imaging group. Ward Fickweiler from Joslin will be doing systemic biochemical and cellular markers. And Tianen Tan from Singapore will be scribing for our visual function and retinal physiology group. So they will be taking down all of your comments, and then we'll look forward to synthesizing those comments in reporting sessions right after the groups. I'll just make one last comment, which is that all of our breakout leads recognize that we have very ambitious goals set ahead of us. So we're going to be directing the conversation quite heavily. Please do not hesitate if you have additional comments or questions to write them down and just send them to us by email. If you're on Zoom through the chats, we would be really delighted to hear them.